I guess if I may, I'm a little bit more curious about the vaccination process that you sort of skipped over there about the emergency use authorization. So at one point you said it wasn't about time, it was about the
Numbers.
numbers.
Yeah.
So, obviously, even though that is a mute point, like it's already, where we have the full authorization now. I think still having had that emergency use authorization, and then, I think it was, oh, well, now they hurried it up through or so, like, I guess to just say more about that,
Yeah.
because I know that this was kind of in the works with the SARS and MERS and other.
Yeah. Yeah, that's a great question. So this isn't like a football team. So by analogy, right? When we started developing the COVID-19 vaccines, particularly the Pfizer Moderna vaccine, it wasn't like you were starting on your own 1 yard line and having to run the length of a football field to score a touchdown. It was more like starting at your opponent's 30-yard line. There was a lot of work that had already been done, legwork that had been done well before, right? Particularly because of SARS in the early 2000s. They started to work on developing vaccines then. So when it came to COVID-19, the blueprints were already there. What they needed was the money, right, which they got from the federal funding. They needed the money and the ability then to find the right genetic sequences, right, to get the vaccines to actually attack the right virus. Okay. And as Dr. Fauci has said on a number of occasions, the technology that was utilized in developing those genetic sequences isn't your father's old genetic sequencing technology. It was a little bit of a dry humor on his part, but we'll forgive him. And so there was already an accelerated, it wasn't like they sort of hurried up and started from scratch, right? It'd be like revising a paper that you've already spent a year working on and then saying, now it's good enough. And so once they've gotten that, and then there was the funding, and then just the sheer numbers, right? So one of the things that often delays vaccine development and approval through the FDA is having enough people to vaccinate, right? And enough people to study. Well, this is a global pandemic, right? There are people all over the world who are now getting these vaccines that they could look at the numbers. And that's what I was saying when it's not so much about time as it is the numbers when we're looking at the effectiveness of the vaccine. We had millions and millions more people across the globe who were getting the vaccine that we could then assess the data, and they could do it very quickly as a result of that. It's a great question.
We have a couple of questions now in the chat. The emergency youth authorization program. The Pfizer vaccine has already been shown to be less effective in requiring a booster, especially against the Delta variant. Many have been vaccinated with the 2 doses of Pfizer and now getting COVID and needing the booster. So, was the EUA has rushed things. So is this an issue where that's actually failed, that using the emergency use authorization has shown that it's not actually a good thing to do? And also on top of that, the student has a question about the first 2 diseases, smallpox and influenza. Why aren't we mandated to get vaccines for influenza, for example? So I guess there's 2 questions. One, the emergency use, and isn't Pfizer proving it's not a good thing, or it should have taken longer? And 2, why not influenza?
Yeah. Really, really great questions. So thank you for asking both of those. Let's try to separate out the EUA process piece, right? So let's say, look, even if it went through the formal slow process, right, the slower process and getting the full approval off the bat rather than the EUA, you would still have the same problem that we have, where people who are getting the COVID shot initially are now can still get sick with COVID. And the reason for that is because the disease mutated, right? And we got the Delta variant as a result. And the vaccines, the original iteration of the vaccines, were under what are known as the alpha strain, right? The original strain of COVID. And so as the Delta variant comes up, now we're seeing, oh, look, the vaccines are effective, but they're weaker, right? They're not as strong against this Delta variant. But what I can tell you is what the data shows is that the people who are vaccinated who are getting COVID are not going to the ICU. They're not getting serious illness, especially to the degrees that we're seeing the unvaccinated. We have 80 and 90-year-olds in the hospital who come in and say, I've been vaccinated, they have COVID, and they do good. They're hanging out in their rooms. They don't need to go down to the ICU. Most of them don't even need breathing masks, right? And so there's a bit of perhaps a bit of ad hocness to this, but it's really not. We're observing, right? Those who are vaccinated do better when they get COVID. And so we're seeing, okay, now that there is this additional strain out there, there's the need for a booster, right? And that the booster seems to help people prevent them from getting the Delta variant. The speed at which the data had been reviewed, could that have caused and been an effect here with respect to this? Maybe. If you had slowed the process down, what I worry about is if the process was slower and it took longer to get the vaccine out, you would have had more people who were not vaccinated who were getting sicker, and the virus would have mutated perhaps even faster, and we might have even more variants that we need to be mindful of. So I'd be cautious in thinking that the EUA process is equivalent to, or the reason for why we're in the situation now with people who had the COVID shots who are now needing boosters, and people with the COVID shots who are still getting the disease. So similarly, right? Think of the analogy here of wearing a seatbelt, right? I wear a seatbelt so that hopefully I don't get into a traffic accident, right? That wearing a seatbelt indicates that you're a mindful driver. It doesn't mean you're never going to get in a car accident, right? And you might get into a car accident, and I'll tell you, if you get in a car accident, you're wearing a seatbelt, the majority of time you're going to be a lot better off getting into a car accident with a seatbelt on than with a seatbelt off, right? Are there some exceptions where seatbelts have created a problem for people? Yeah. But we don't flip it right now and say, well, you know, this number of people died because they got into car accidents with seatbelts, so ergo, we're not going to have people wear seatbelts anymore. That's not the position to have, right? Because the data overwhelmingly shows the people that get into car accidents with seatbelts survive at much higher rates than people who don't. So I try to think of it in terms of those analogous points. Now, the second question, which is also really good, and perhaps a little bit similar to the seatbelt analogy. I can tell you, at least within health professions work and working in hospitals and health systems, we are required to get the flu vaccine. Surprisingly, there are some places that make that a fireable offense, right? So Medical College of Wisconsin, I just found out, they have a flu vaccine mandate, and they will fire staff who don't get the flu vaccine. Here at Gunderson, we have a flu vaccine mandate, and those who don't get the flu vaccine have to take mitigation strategies to prevent themselves from potentially infecting others. The other thing, though, with respect to flu is that while flu is deadly, it doesn't affect the broad population nearly as much as COVID has affected the population. And what we've learned about COVID is that the people who get sick with serious disease of COVID are far sicker than those who get sick with serious disease of flu. And what we're seeing also with the Delta variant, whereas the original, the alpha strains of COVID were affecting those older populations. Remember, we were saying we're really concerned about our grandparents and not wanting them to get sick, right? Our 60 to 70-year-olds to 80-year-olds getting it. The worry with the Delta variant is actually your middle-aged white male, right? Those are the individuals who are ending up in the ICU intubated with a range of 30 to 60, right? Those are the ones, for whatever reason, with this virus, the older populations are less susceptible to it. This iteration of COVID affects the middle-aged white male more than others. And we're not sure why or how that's happening, but that's the impact that we're seeing. And there's a couple more questions, I think.
Yeah. So the next question is why, now maybe you know the numbers on this. So I guess it's why is there a large quantity of medical professionals that have yet to get vaccinated when the science points to the vaccine as very effective and safe, especially with all of the overrun hospitals with COVID-6 patients that many of these professions are witnessing firsthand?
Yeah, that's another really great question. I don't know numbers exactly off the top of my head. Um, Matt Winia actually has an article on this. It can actually be broken down by profession, right? So your MD level providers have very, very high rates of vaccination, right? Usually 95+%. Our staff, overall staff here at Gunderson, we're at 85%. UW-Madison, University of Wisconsin-Madison, we just found out yesterday, is at 99.6% of their staff are vaccinated. So they are getting vaccinated. And this is again where I'd say we want to be careful about looking at the numerator versus the denominator. Sometimes the loudest voices in the room seem like they're the majority, but they're not necessarily the majority. Certainly there are large, what we might consider large numbers, right? Hundreds. If you're in a system of 70,000 staff and you have 2,000 to 3,000, we're like, wow, that's a huge number of people not getting vaccinated. Yeah, that's a big number. But by comparison to the overall population, it's not as big. And again, what you can see is that there is a higher rate of vaccine hesitancy or refusal among particularly nursing staff compared to your MD staff. The reason why, I'm not really sure. And it's not that many of them distrust the science. And I think what you're seeing here is when you look at other vaccines, there's less hesitancy with vaccines like the flu vaccine, right? Overwhelmingly, people within the healthcare realm accept flu vaccine. There's greater hesitancy with the COVID-19 vaccine. And I don't want to speculate on all the different reasons why that's the case, other than to say I think it's a conglomerate of different reasons of how as a culture, as a society, we've talked about COVID-19, how we've talked about in a wide way the safety of the vaccines, the origin of the vaccines, et cetera. So that's how I'm going to try to answer that and to say, I think for the most part, you are seeing large numbers of people getting vaccinated. There's also people not getting vaccinated, and their reasons are not always sound with the science.
I think there's a follow-up. I understand the scientific process, but many are waiting to make sure this works. I think then you've really answered. So just so I'm clear, if the virus is safe, it's effective for 6 to 8 months. The other side of it works, but it's also not harmful. So even if it only protected you for 6 or 8 months, you're protected from 6 or 8 months of spreading, and there's not a negative to it. So there's only, in that sense, there's only a positive, right? So I guess to say that to make sure it works, if you're looking for perfection, we know that's not likely in any vaccine, right? Even the influenza, we've been having influenza shots for how many decades now. And I know that I've gotten the influenza even after I've had it, but it's always been a mild case after I get my shot. And the years that I didn't get a flu shot, it's been a very severe case, but it didn't stop at every influenza outbreak. But the difference between being sick for a day and being sick for 4 or 5 days or worse, that's what we're looking at here. So even with COVID, even if it's to say, I guess, maybe Joseph, if you have some, you want to refine the question, but it seems to me it does work. In other words, it does work. It just might not work like other vaccines that last 20 years or 15 years, or the MMR, and right, those last several years before they start to wane.
And we know too that the younger you get people vaccinated, right, the longer the vaccine lasts. We know that certain viruses, for whatever reason, mutate at a faster rate, right? This is why we do booster shots for the flu vaccine every year, just like what you're saying is there are different strains that come out every year, right? And so the previous vaccine was effective against a particular strain. It's not as effective against the newer strain. Chickenpox doesn't mutate as quickly as flu does. right? And so what we're seeing is with the COVID-19 disease, or I should say virus causing disease, is that the virus itself has mutated and has had multiple variants. Um, one of the other interesting things here, so as was noted, I was sitting on the vaccine allocation committee here in Wisconsin, and it was our job to figure out who gets the vaccine first, right? Because you remember back in winter of last year, late December, early January, we knew we were going to get vaccine, but we knew we were going to have really limited quantities, and so we had to figure out who was going to get it first. And all of us on that committee were very surprised one day, just seemed like it happened out of the blue, when we were told by the Department of Health Services for Wisconsin, by the way, mink farmers are eligible in the first round to get the vaccine. We said, what? Mink farmers? A lot of us didn't even know we had mink farming. Turns out Wisconsin is the top mink farming industry in the United States, right? And actually the world, up in the upper eastern portion of the state. Why mink? Well, mink pose a bioterroristic threat, right? And so there's a zoologic reason in which humans can pass a virus to a mink. The mink, for whatever reason, the way that their metabolism works is they can metabolize and mutate a virus very quickly and then pass it back to humans. And so he said, oh, we got to get these folks vaccinated quickly. None of us on the committee knew that. And all of a sudden we're going, wait, and there's about 200 people, right? So they're going a pretty low number of folks, but those are the weird things that you learn about viruses, is how they mutate. Sometimes they go really quick, sometimes they don't go as quick.
Other questions before we?
Actually, could I just ask a follow-up real quick on the variants? So one of the arguments that I didn't hear in your presentation, which I thought maybe I might, is the idea that because the COVID-19 virus has mutated and we get so many variants, and it's the Delta and now other variants, and the Delta has variants and all this, is one concern that it would just obviously keep mutating the longer that we don't reach herd immunity, and that we're going to get this, really problematic kind of strain that's not going to be responsive to the vaccine? Or is that too far out? Because I know you mentioned the proximity issue with the ethics of risk. Is that too far out to be an ethical concern?
Yeah. No, I think it's an important concern to be mindful of. This is one reason why you're seeing, especially health systems, saying we think, and really health departments, not so much health systems, but large governments saying we want to get this under control now, because what we're worried about is this future unpredictable state. One of the things that I remember Fauci saying early on that I thought was really telling, and I think he's right, is he said, if we don't get a handle on this now, and I think we might already be past that point of no return, is we're going to transition from pandemic to endemic, right? So it's going to be here, and it's probably going to be here forever unless we're able to get a handle on it with the vaccines and like smallpox, over time have it eradicated. But it takes the collective will of people to do that. And I see one of the questions here in the chat box around the CDC and the vaccine and not stopping spreading of the virus. That has a lot to do with viral load, right? So you are less likely to spread COVID-19, especially the ancestral strain of COVID-19, with the vaccine, because your viral load is much lower. With the Delta variant, you can have a higher viral load. You might not get as sick because you're vaccinated, but you can have a higher viral load. And when that starts to shed, that's when you begin to put other people at risk. And one of the things I didn't talk about in here that bears mentioning. So some said you might have seen out there about the Delta variant being as infectious as chickenpox. What does that actually mean? What that means is if you have COVID-19, the ancestral strain of COVID-19, the one we were really worried about at the beginning, it was actually low infectability, all things considered, right? The challenge was it was infectious and it was deadly. And so if you had COVID, you could expect with the ancestral strain to infect 2 to 3 people before you began to become symptomatic, right? So that means 2 to 3 people that you came in contact with would get COVID before you ended up feeling like crap from COVID. So that wasn't good, right? And you can think about the numbers and how that goes out exponentially. With COVID Delta, that jumps up to 6 to 9. So you can infect up to 6 to 9 people with the Delta variant before you actually start feeling sick from COVID with the Delta variant. That is a really scary thing, which is another reason why they're saying we really want to get a lockdown on the vaccination piece in this, because if it's so highly infectious, then we want to make sure that if you're going to get sick, that at least we minimize the impact of the disease, right? So the other thing I'm often reminded of, and I know we're running short on time, but the early on, and what the public messaging was, and probably still should have been, was we're not trying to necessarily stop the spread of the disease, right? That's a noble goal, but what we really want to do is slow it down enough so that when people are infected by it, right, we're not overwhelming our health systems where we're not able to provide the care necessary, right? We are in now what is nationally being called the 4th wave. I can tell you here locally, we're in our 2nd large surge. Right? We had a huge surge in November last year, directly tied to in-person classes at the local universities. We actually have statistical data that demonstrates that the variants that were found in that surge were traced back to the opening of the colleges here locally in La Crosse and coming back in person. Where we are now is we're having another big surge, right? And that big surge of the Delta variant, where people are coming in and they're coming in with extreme illness, and frankly, they're utilizing more resources now than they did last fall, and that's really, really, really scary. We're better now at treating COVID, so fewer people are dying from it in the ICU than they were a year ago, but there's more of them. Not a trade-off I'm particularly happy about. I'll take strain on resources over death, but the strain on resources really sucks.
There's another question.
Yeah. Oh, do you want me to wait?
Yeah. Why don't you go ahead, and then we'll get to the one in the chat. So go ahead, Nicole.
So my question's about herd immunity, because
Yeah.
my family has been one of those people that have been like, no, everybody's going to get okay. And they were really reluctant to get the vaccine. And I've really pushed hard. And I've gotten a few members of my family to get it. But I also have friends that are like, we'll be fine. I'm young. I'm healthy. Herd immunity's come. I don't think people understand herd immunity, and neither do I. What are the numbers to reach that point? Because we've already lost so many people, and it seems like we still don't have herd immunity.
Yeah, right. Well, so herd immunity is a function both of numbers and variance, right? So that's a really good question. The target is 80 to 85%. We thought it was going to be about 60%, and then realizing that actually through the projection models that were used, and this is coming from the work that Zeke Emanuel did on some of this as well. Herd immunity generally requires an overall population of about 65 to 85% of the population getting vaccinated. What we know is that never in the history of humankind, recorded history, I should say, has a people gotten to herd immunity without the aid of vaccines. It's never happened through natural disease, ever, right? And so, for example, if we didn't ever have the smallpox vaccine, it would still be around, right? It would still be a problem. it was only because of the vaccine that it was able to be eradicated, not because it somehow everybody got it and we got better at it. Part of the issue here too is with herd immunity, it's a population issue as well, right? Obviously. And what happens to a population is that it tends to grow exponentially. So the more people you have, the more people that you have to immunize, right? And so you have to look at time with respect to that. So I'll give you just a quick example. What is the, somebody quick pull it up for me. What, actually, I'll do it while we're talking. Current world population. Hold on a second. We'll just get a quick gander here. So 7.75 billion people on planet Earth in 2020. Just 20 years ago, it was 3 billion. So in 20 years, our population has more than doubled on planet Earth, right? And that's incredible, right? That's the exponential growth. And so that when we talk about herd immunity, you can't ignore the fact that your population continues to grow. And as the population grows, you need to get more people vaccinated to get that done. The herd immunity is great, but you can't get to herd immunity just by relying on people to get natural infection. Not only that, but it's kind of a weird argument, right? In the sense of, well, everybody's going to be okay. And if I get it, I'm going to be okay. One, you don't know that. Two, wouldn't it be better if you had an opportunity to have a shield, to go into a fight with a shield rather than not having a shield if you're going to go into a fight, right? A vaccine is like having a shield, right? And you might survive the fight and you might come out okay. Why would you risk that for yourself or your loved ones? And I get it. People will say, we're going to be okay. We're going to be okay. Maybe as a species, sure. In the meantime, we have here in the United States, right? 700,000 people who have died because of this disease that we didn't have a really good opportunity to save. That's 700,000 families that are impacted, right? 700,000 families, young, many of them young kids. Look, and I'm not trying to get on a soapbox and now get into this emotional aspect of this, but you know, I had a mother of 4 last week in the ICU, died, COVID, 4 children, right? It's a relentless disease. It doesn't give a shit about your age. It doesn't give a darn about whether you think you're strong or not. It doesn't care. It wants to eat you alive, right? And it makes sense that you would at least try to protect yourself or at least your loved ones from that potential. Might you be okay? Sure. I could throw a bullet and a gun, spin it around, and maybe I'll be okay with Russian roulette. Not a risk I'm willing to take. So that's sort of where I would put that. And to say, yeah, we might get to herd immunity, but it ain't going to happen without vaccination. It's a great question.
Yeah, I think you answered it. Oh, I'm sorry. I just want to say you answered the question. I just don't think that a lot of people didn't understand the fact that herd immunity isn't going to come without a vaccine. I think that people believe just from the title herd that it's going to come natural the way animals are in herds, and it's not.
Right.
And I think that that needs to be explained to the public more.
Yeah, again, that's exactly right. The public messaging around this has not been very good, right? And to say, yes, we want to get to herd immunity, but we need to do it through this mechanism to get there. Yeah, I totally agree with you.
As the question, I don't know if you want to read it right from the chat there, about the high opposition because of the media. What you think, does that contribute to part of?
So when people, yeah, you know, I do. You know, one of the things that is very easy to do is to become resentful of people who challenge things that seem factual, right? So when you say, here's what the data shows, here are the numbers, and people say, I think your numbers are wrong, right? Or you're lying, or you're somehow, you're a mastermind behind a conspiracy. It's very easy to get resentful, and as a health provider to start to feel complacent, or lose your compassion. And what we try to remember is, and the message we try to get across around the moral resiliency piece is, the people are not the enemy. Our fellow man and women, et cetera, are not the enemy. The disease is the enemy here, right? Is there a hurdle that we got to get over? Yeah. Are there lots of reasons why that hurdle is in place? Yeah. But if the media can be used in a way that facilitates a distrust, the media itself, it's like a tool, right? And a tool can be used for good or not good, right? And the media can be utilized to help facilitate trust as well. How you do that, totally different talk for a totally different time. You could probably have an entire course on that, right? Of what it is to facilitate trust.
Can I ask you a question? So I'll take a chance to jump in here. The spread, one of the things that I don't know if, and I don't know if I've seen anything, the spread between vaccinated people. So let's say you've got a car full of vaccinated people. All of them have got the COVID vaccine. One of them actually is exposed. What are the odds of that person, that viral load affecting someone else in that car with the viral, or the odds of getting sick at that point? I mean, is it something, we're said that we can socialize with people who've been vaccinated, right? And, you have your family.
I don't know the numbers off the top of my head. It's low. I don't know the exact numbers, so I don't want to speculate on that and have somebody go, well, Harter said, it was like 2%. I don't want to make that risky move, but it is low, right? So if everybody's vaccinated, some person's exposed, the likelihood of that person becoming ill and then spreading it to others is low. It's low. It's much lower when all of those folks are masked, right? And you can get it close to zero by being vaccinated, by having the mask, by all the mitigation strategies, which is kind of what we're hoping for. If you can make it close to zero, you could stop the spread entirely, and you really can eradicate the virus, right? And that would be awesome. But that's a great question.